Hello, everyone. My name's Professor Peter Nash from the School of Medicine, Griffith University in beautiful downtown Brisbane, Queensland, Australia. Today, I'm going to talk about a topic of interest, an area that I think all rheumatologists have to get their head around and learn about. We've all heard of the obesity epidemic. We've all heard about the new drugs. In fact, Novo Nordisk made $7 billion in the first 6 months of this year, changed the interest rates in Denmark. It's now Europe's biggest company as a result of their obesity drugs. And there's a whole lot more on the horizon. Why am I even mentioning it? I was interested in a small abstract, a poster. Sorry, it was an oral presentation by Kara Kabili in ULA Milan, where these guys took the health data from British Columbia and they looked at a weighted population-based cohort, and they did propensity scoring, but they looked at 11,000 patients with autoimmune diseases, rheumatoid, PSA, AS, the ones we treat every day, who happen to be type 2 diabetics. Now, I was just in the Middle East, 35% of them meet the definition of obesity. I'm sure it's not very different in Australia or the US, and 19% meet the type 2 diabetes criteria. So this is very, very common and will be common in our patients. So they took 11,000 patients and they didn't compare with controls. They didn't compare with autoimmune disease not on therapy. They simply looked at any difference between the GLP-1 agonists like semaglutide, which is Ozempic and Wegovy, or they looked at DPP-4 inhibitors, which raise the GLP-1 level, sitagliptin or saxagliptin, and they found that they could reduce all-cause mortality and they could reduce MACE with the agonists versus the inhibitors. So it started making me think about obesity in our patients, and we know there is strong evidence that obese patients have high disease activity, poor mental health. Obesity can be a risk factor for the development of psoriatic arthritis in the psoriasis population. We know that from evidence from Den Hollander that increased body mass index contributes to MRI radiographic progression, that if you lose weight, you can achieve minimal disease activity 6 to 7 times more often than those that do not lose weight. This study from Domino showed that losing 5% of body weight, you're 4 times more likely to be an MDA if you had psoriatic arthritis, and 7 times more likely to use 10%. We know that you can make a table now where you can show that the TNF inhibitors have a negative impact on high BMI, and that it interferes with the response to treatment, that some of the other drugs you also need to be careful with. But you can achieve things like 16% weight reduction with the highest semaglutide dose in phase 2 obesity trials. There are a number of these analogs. There are dual GLP-1 GIP agonists, one called tirzepatide, which is available for treatment of diabetes, and very soon the FDA will make it available for the treatment of obesity. There's at least 4 DPP-4 inhibitors. These agents can act at brain levels to suppress hunger, pancreas to stimulate insulin release, suppress glucagon secretion during hypoglycemia. They slow gastric emptying, and occasional gastroparesis is seen, and they increase fatty acid and glucose uptake by their fatty tissues. They have very widespread effects on with proven cardioprotective effects on mortality and MACE in obese populations. So we have yet to come to terms with this whole group of therapy in many situations. You can reduce hemoglobin A1C in diabetics, you can reduce weight, you can reduce blood pressure, and you can clearly reduce MACE, MI, stroke, and cardiovascular death. And that has been shown with both groups of drugs, the agonists and the antagonists. Jack will be interested in a study shown in JAMA, Network Open 2023, that you can reduce gout flares and mortality if you use these drugs in diabetic patients who have gout. So that's already been shown as an active comparator study. From the side effect profile, you can get some UTIs, some mycoses, some hypoglycemia, gastroparesis, but in the main, very well tolerated. There's the injections and there's the tablets. And I really would encourage you to start thinking about not only your diabetic patients, but think about doing formal studies in obesity, in patients with rheumatoid arthritis, particularly those with high cardiovascular risk, and get your head around this whole group of drugs, the agonists and the inhibitors. And again, there's a nice paper in Clinics of Rheumatology, 2023, March 6, by Karakabi Lee, and it's called the GIP receptor agonists in patients with inflammatory arthritis, a scoping review. I recommend you have a look and we start thinking about this problem, which will just increase over time in our patients. So thank you very much. Signing off and back to Jack.